Welcome to EMDR, the science behind the therapy, a podcast from the Sonoma Psychotherapy Training Institute. I'm your host, Dr. Andrew Leeds. In each episode, we explore the latest research and clinical insights about EMDR therapy, highlighting the leading scholars' latest contributions to EMDR research, education, and training. Whether you're a therapist, a student, or a lifelong learner, I'm here to connect you to the science behind the practice of this remarkable form of psychotherapy. I welcome your feedback and suggestions for topics to be considered or any issues you encounter in my summaries of the research. You can reach me through the Contact Me form on any of the websites listed in the show notes. Before we start, I want to draw your attention to the unique EMDR therapy training delivered by Sonoma Psychotherapy Training Institute. Sonoma PTI provides a comprehensive program in 4 two-day modules spread over a 12-week period. These 4 modules include all required hours of lecture, practice, and group consultation. Our Zoom-based program is open to clinicians from throughout the United States, Canada, and Europe. I invite you to look over our curriculum and training schedule at sonomapti.com. This month, we explore how EMDR therapy is being adapted and scaled to meet trauma where it is found, in hospitals, clinics, homes, and war zones. From meta-analytic evidence on brief online group EMDR interventions for healthcare workers during the COVID-19 pandemic, to innovative group protocols that helps overstretched public health systems reach people on long wait lists, these studies show how EMDR therapy can be delivered efficiently without sacrificing depth or safety. We will look at help for parents of children with neurodevelopmental disorders receiving intensive group EMDR therapy over 3 days. Older adults using EMDR to reclaim movement and daily functioning from chronic pain and fear of movement, and Ukrainian clinicians applying EMDR-informed low-threshold trauma support in the midst of ongoing war. We conclude with a conceptual deep dive into the EMDR Toolbox Method for complex PTSD and dissociation, which offers a structured way of mapping internal states and guiding treatment in highly complex presentations. Together, these reports trace a consistent theme: EMDR therapy as a flexible, scalable approach, capable of reaching large and diverse populations while still honoring the individual stories and nervous systems behind the data. To access any of the original papers mentioned in the podcast, you will find a complete list of references and links to each of these studies in the April 2026 blog on sonomapti.com. A link to these references can be found in the show notes. You can also just go to sonomapti.com, click on the blog section on the far right of the menu bar, and then select the April 2026 listings. So let's get started with the background to today's episode on EMDR, scaling from war zones to waiting rooms. We begin this month's episode with a series of studies extending the research of group EMDR therapy protocols. First, a meta-analysis, and then 3 mixed method reports on group therapy interventions. In February 2026, Harrison and co-authors published a systematic literature review and meta-analysis evaluating EMDR therapy as an early intervention for COVID-19-related psychological distress in healthcare professionals. They synthesized results from 13 quantitative studies, including randomized controlled trials. Most were group-based interventions conducted online. The reviewed studies report on treatment delivered to over 1,600 healthcare professionals in Italy, Turkey, Egypt, Ireland, Canada, Mexico, and France. These studies employed a diverse range of standardized measures for PTSD, anxiety, and depression, as well as instruments assessing sleep quality, burnout, self-efficacy, and post-traumatic growth. Their meta-analysis found that EMDR therapy produced large and statistically significant reductions in PTSD symptoms. Many of these studies reported post-treatment scores below clinical cutoffs, with maintenance of gains at follow-up. Secondary outcomes showed consistent, clinically meaningful decreases in anxiety, depression, and fear of infection, along with improvements in sleep, stress regulation, work attendance, self-efficacy, and post-traumatic growth. Comparison studies reveal that EMDR therapy outperformed psychological debriefing and matched trauma-focused cognitive behavioral therapy in effectiveness. EMDR therapy achieved these results with brief treatment, often with a single or with just a few sessions delivered remotely or in groups during ongoing exposure. Harrison and co-authors noted some important limitations, including inconsistent methodological quality, small and self-selected samples, and limited or absent control groups. The studies employed divergent EMDR therapy protocols and outcome measures with short or inconsistent follow-up periods. There were some indications of publication bias and high statistical heterogeneity, which constrained causal inference and prevented identification of the most effective treatment protocol. They concluded that EMDR therapy showed promising evidence as a flexible, scalable, early intervention that could reduce PTSD and broader psychological distress among healthcare professionals during COVID-19 and possibly in other ongoing trauma contexts. They also emphasized the need for more rigorous controlled longitudinal research to clarify mechanisms, optimal protocol choices, and durability of effects. In March of 2026, Lofthouse and co-authors published a mixed methods service evaluation of the group traumatic episode protocol as an EMDR therapy-based group intervention for adults with heterogeneous trauma histories. These studies selected patients on a UK National Health Service waiting list for individual trauma therapy in South Wales. The design used a pre-post uncontrolled evaluation of 8 to 10 weekly in-person groups, facilitated by accredited EMDR therapy practitioners. 23 of 30 attendees provided complete outcome data. Measures included the clinical outcomes and routine evaluation outcome measure and the International Trauma Questionnaire. Participants also completed a brief qualitative feedback questionnaire that underwent thematic analysis. They found that mean International Trauma Questionnaire 18-item symptom scores decreased from about 37 to about 18.5 with a large effect size. 83% of participants showed reliable improvement, while 55% of those who initially met criteria for PTSD or complex PTSD no longer did so post-group. Clinical outcomes in routine evaluation outcome measure scores fell from about 24 to about 13 with a large effect size. 74% achieved reliable improvement and 39% met criteria for recovery. Qualitative analyses identified perceived gains in connection, emotional safety, and trust, validation and normalization of trauma responses. Patients reported meaningful symptom changes, including better sleep and confidence, appreciation of practitioner qualities, and specific benefits of the structured EMDR therapy worksheet format that avoided any need for disclosures. Lofthouse and co-authors acknowledged some limitations: the absence of a control group, the small sample size, missing post data for 7 participants, lack of follow-up, brief written qualitative data, and no comparison with individual EMDR therapy or trauma-focused cognitive behavioral therapy. They concluded that the group traumatic episode protocol appeared feasible and acceptable as a group EMDR therapy option for NHS clients with diverse trauma histories and might help alleviate service pressures by offering a structured, time-limited, scalable approach. They stressed that larger, controlled, and longer-term studies are needed before positioning it alongside first-line trauma treatments. Cavallera and co-authors conducted a randomized controlled feasibility study that compared an EMDR therapy integrative group treatment protocol for ongoing traumatic stress with a waitlist control in 34 parents of children with neurodevelopmental disorders. Parents were assessed at pre-test, post-test, 1 week after treatment, and at 3-month follow-up. Parents met inclusion criteria based on elevated scores on the Impact of Event Scale Revised and completed a demographic and clinical questionnaire. Outcomes were assessed with the Impact of Event Scale Revised total and subscales, the subjective unit of disturbance scale for the most stressful parenting event, and a therapeutic process diary after each of the 6 EMDR therapy sessions, which were delivered over 3 consecutive days. Cavallera and co-authors found that compared with the controlled condition, the treatment group showed significantly greater reductions in Impact of Event Scale Revised scores and subjective unit of disturbance scale scores from pre-treatment to post-treatment and at 3-month follow-up. There were large effect sizes and high post-hoc power. Within-group analyses showed significant decreases in both measures over time in each group, but changes were larger in the EMDR therapy group. The number of sessions attended significantly predicted the magnitude of symptom reduction. Cavallera and co-authors reported additional qualitative findings from parent diaries. Participants rated perceived usefulness highly and increasingly described pleasant aspects such as a sense of agency, self-awareness, and increased calm, while unpleasant aspects such as difficulty managing emotions decreased over time. Years since their children's diagnosis correlated with smaller long-term Impact of Event Scale Revised improvements, suggesting that more chronic caregiving burdens limited the durability of gains. Cavallera and co-authors noted limitations, including the small sample size, reliance on self-report, use of a waitlist rather than an active control, a wide range of neurodevelopmental diagnoses, and an exploratory design that did not allow firm efficacy conclusions. Overall, Cavallera and co-authors concluded that this brief, group-based EMDR therapy protocol appeared feasible, acceptable, and potentially effective for reducing PTSD-related parental distress, warranting larger, well-controlled trials and earlier implementation after diagnosis to better support family-centered care. Next, we turn to a remarkable humanitarian study of an EMDR-informed trauma-focused approach that was delivered by Ukrainian therapists to more than 1,200 clients in Ukraine during ongoing war conditions, with a range of individual, group, and family formats. Uda Sodman, Peter Bumke, and Frank Hoffman used an observational mixed methods design to evaluate the Trauma Psychosocial Support plus EMDR Elements program delivered by 31 trauma counselors. Their work was organized under the auspices of Trauma Aid Germany and was supported by public and private donations. The training of clinicians in Ukraine began in 2017. The report was published in February 2026 in the Journal of EMDR Practice and Research. The TPSS Plus program is a brief, structured, trauma-focused approach that prioritizes stabilization and resources before any trauma exposure. Counselors begin with psychoeducation on trauma and normalization, explaining stress reactions and the window of tolerance to orient clients. Then they use stabilization tools, such as the container exercise, the safe place procedure, breathing and sensory grounding exercises, and simple guided imagery, supported by slow bilateral tapping to enhance self-regulation. This is followed by resource activation, which is the terminology used by Trauma Aid Germany for their version of a resource installation procedure. Resource activation focused on the position of power, positive future imagery, and resource drawings to strengthen internal and external supports. After these initial psychoeducation and stabilization interventions, counselors introduced mild to moderate exposure tools, such as the four-field drawing technique, pendulation between distressing and safe material, and other brief EMDR-derived procedures using tactile or auditory bilateral stimulation. Across a range of individual, group, and family formats, the goal was always to improve well-being, coping, and relational functioning, and to identify who might later benefit from full standard EMDR therapy with reprocessing. This team initially studied resource activation in the first randomized controlled trial of resourcing conducted in Cambodia and reported on in 2016. The TPSS Plus program was further developed and reported on in 2021 during a mental health training program in Kurdistan. To assess these multifaceted interventions in their implementation in Ukraine, they integrated monitoring data, pre-post standardized scales, and qualitative material from therapists combined with selected case studies. Quantitative measures included the WHO-5 Well-Being Index, the Rosenberg Self-Esteem Scale administered before and after TPSS Plus, alongside demographic treatment and traumatic stress data. They found that clients across age groups showed substantial gains in well-being. WHO-5 scores increased on average from about the low 40s to the low 60s. Both group and individual formats improved outcomes, although individual work yielded larger mean gains. Self-esteem scores showed small overall changes, but those clients who started with low self-esteem demonstrated marked and statistically robust improvements. General linear models indicated that minimal trauma confrontation, higher session numbers, and being a child or adult predicted larger WHO-5 gains, while gender, setting, and stressor type did not significantly differentiate outcomes. Udesodman and co-authors also reported rich qualitative evidence of change, including reduced anxiety, improved sleep, enhanced emotional regulation, and shifts in family and social functioning for children, youth, and adults. They described how TPSS Plus techniques such as stabilization, resource activation, and moderate exposure appeared to support clients coping in the context of chronic war-related stress. They noted that outcomes were constrained by continuing adversity, that psychometric tools captured only part of the change process, and that lack of independent outcome assessment, incomplete data sets, and contextual instability were further limitations. They concluded that the Trauma Psychosocial Support Plus EMDR Elements program functioned as a feasible, low-threshold, trauma-focused intervention that improved well-being with diverse groups in Ukraine, while simultaneously strengthening trauma counselors' own resources. They proposed that integrating quantitative indicators with systematically analyzed therapist narratives offered a more nuanced understanding of therapeutic impact. They suggested that TPSS Plus could serve as a scalable bridge to EMDR therapy and related services in crisis regions, with future work needed on long-term follow-up and broader implementation. Our next report answers the question, can a brief EMDR therapy intervention help older adults overcome their fear of movement due to chronic pain? Jamshidi and co-authors published a single-center, assessor-blinded, randomized controlled trial in February 2026. Participants were 62 adults, aged 60 to 75 years, with chronic multi-site musculoskeletal pain and clinically meaningful fear of movement. The study, carried out in Rafsanjan, Iran, was designed to test whether a 6-session EMDR therapy protocol improved functioning in older adults and reduced fear of physical activity, identified in this study as kinesiophobia. Participants met inclusion criteria. They had chronic pain at a minimum of 2 different locations, scored at least 37 on the Tampa scale for kinesiophobia, and showed intact cognition on the mini mental state examination. They were randomized to EMDR therapy or a waitlist control. All participants continued to receive their usual care. Outcomes include scores on the Tampa scale for kinesiophobia and 2 scales on activities of daily living. These tests were administered at baseline, immediately after treatment, and at 1-month follow-up. They found that just 6 sessions of EMDR therapy produced large and statistically significant reductions in fear of physical activity compared with controls. In the EMDR group, the Tampa scale for kinesiophobia scores dropped from an average in the mid-30s at baseline to about 20, compared with the control group scores, which remained high and slightly worsened. These gains persisted after 1-month follow-up. EMDR therapy also yielded significant improvements in basic activities of daily living, with mean scores increasing to near maximal independence. In the control group, kinesiophobia slightly increased and functioning did not improve, demonstrating that the observed benefits were not due to natural recovery. Jamshidi and co-authors noted several limitations, including reliance on self-report without objective movement assessment, a modest single-site Iranian sample, a short 1-month follow-up, and a wait list rather than active treatment control condition. This prevented causal attribution to a specific EMDR therapy mechanism. Despite these issues, they concluded that brief EMDR therapy represents a promising, low-burden, non-pharmacological intervention for older adults with chronic musculoskeletal pain and an elevated fear of movement. They proposed that the mechanism of action involved modulation of amygdala-based fear circuits and suggested EMDR therapy should be integrated into stepped care, trauma-informed geriatric pain management treatment models. Our next report is from Italy, of a randomized controlled trial with female inpatients with obesity and binge eating disorder. Anigarini, Usubini, and co-authors published a 2-arm randomized controlled trial in 2026 comparing a 4-week EMDR therapy intervention with a parallel cognitive behavioral therapy intervention for female inpatients with obesity, binge eating disorder, and at least 1 self-reported traumatic event. The study was conducted at a residential treatment center for obesity and eating disorders. Participants were randomly allocated to EMDR therapy or cognitive behavioral therapy. They completed pre- and post-intervention self-report measures, and all analyses followed an intention-to-treat approach. The study used the Impact of Event Scale Revised, the binge eating scale, the depression, anxiety, and stress scale, and the difficulties in emotional regulation scale. They found no statistically significant difference between groups, indicating that EMDR therapy and cognitive behavioral therapy did not differ in their impact on binge eating, emotional eating, depression, anxiety, stress, trauma-related symptoms, or emotional regulation. Both interventions were associated with statistically significant but small improvements in nearly all of the standardized measures. However, only a minority of participants achieved clinically significant change. The absence of a no treatment or treatment as usual control group prevented attributing gains specifically to either EMDR therapy or cognitive behavioral therapy. The brief 4-session format, small sample, single treatment center, exclusively female inpatient cohort, and intensive background program limited power and generalizability. Overall, Anagarini, Usibini, and co-authors concluded that EMDR therapy and cognitive behavioral therapy appear to offer similar, modest benefits for inpatient women with binge eating disorder, obesity, trauma history, and PTSD symptoms. They called for larger, longer, and controlled trials to clarify any differential effects. We turn next to a series of reports that involve speculations about EMDR therapy. Some are fairly well grounded in data, and others are perhaps more fanciful. The first two ask questions about potential variations in EMDR therapy procedures. In February 2026, Christy Collins and Jose Carbajal published a quasi-experimental study in the Journal of EMDR Practice and Research to explore whether omitting the use of negative cognitions has an effect on EMDR treatment outcomes. Part of the rationale for their research was a claim that identifying the negative cognition is typically omitted from the standard EMDR protocol when treating children under the age of 6. However, one of the most respected treatment manuals for the use of EMDR therapy with children by Robbie Adler-Tapia and Carolyn Settle encourages the identification of bad thoughts, even for very young children, using concrete child language terms such as "I'm bad," "I'm stupid," "I'm not safe," or "I can't trust anyone." Other rationale included a 1999 experimental dismantling study by Cusack and Spates that omitted the positive cognition from the assessment phase and skipped the installation phase and found no statistical difference between the two groups. Most of the subjects in the Cusack and Spates dismantling research had experienced a single traumatic event. Even so, this dismantling study had a 30% dropout rate and appears to have also omitted the preparation phase. Research on the flash technique was also cited as part of the rationale for studying the omission of the negative cognition. The Collins and Carbajal study was carried out in a community mental health setting and involved 6 adult clients with PTSD who received EMDR therapy from a single EMDR-trained licensed professional counselor. They were alternately assigned to a standard treatment group with identified negative cognitions or to an alternate group in which negative cognitions were omitted. The therapist administered the symptom checklist and the PTSD checklist for DSM-5 at the first session, session 6, and session 8 to capture change over time in broad symptom distress and PTSD symptoms. They found no statistically significant differences between the two groups on either measure. They interpreted these scores as tentative evidence that explicit inclusion of the negative cognition did not meaningfully alter EMDR therapy outcomes in this small sample. Collins and Carbajal noted essential limitations: the extremely small sample size of 3 participants in each group, lack of random assignment, absence of inclusion and exclusion criteria, reliance on descriptive statistics and non-parametric tests, and no fidelity checks on adherence to either the standard or modified EMDR therapy protocols. They also questioned whether the symptom checklist was the optimal outcome measure, suggesting that other instruments might have been preferable. They concluded that in EMDR therapy, negative cognitions remain clinically and theoretically meaningful, but suggested that they might not be essential for symptom change. They called for larger, randomized studies, more sensitive measures, and a range of research designs to clarify the specific contribution of negative cognitions to EMDR therapy outcomes. In February 2026, Ricky Greenwald, Scott McClintock, and Andrew Subert published a 3-part mixed method program of research in the Journal of EMDR Practice and Research, exploring the order of selected targets for EMDR reprocessing. The research began with an online survey of 146 trauma therapists. Then there were 2 quasi-experimental workshop studies with 159 and 114 therapist participants receiving EMDR therapy or progressive counting training. Finally, they reported on an observational case series of 3 adult clients in outpatient therapy whose trauma memories were treated in approximately chronological order. They relied on the subjective units of disturbance scale to repeatedly rate levels of disturbance for targeted and non-targeted memories at multiple time points, including at baseline, after treatment of an earlier or later related memory, and over multiple sessions for the clinical cases. In their survey, they found that clinicians reported a wide range of target selection strategies. The most common strategy was letting clients choose. Other clinicians started with the worst memory or used chronological or early related memories. They explained their target selections strategy as being justified by client empowerment or by speed of relief or by perceived safety. In the workshop studies, targeting an earlier memory significantly reduced distress not only on that memory, but also for later associated untreated memory. Starting by treating a later memory also reduced distress in an earlier associated untreated memory, although the cross-memory effect was smaller when starting with a later memory. In both targeting strategies, greater reduction in distress on the treated memory predicted greater reduction on the related memory. EMDR therapy and progressive counting did not differ meaningfully in this transfer effect. In the case series, as earlier memories were resolved, distress ratings on many later memories decreased, and these gains generally persisted over time, though the extent of cross-memory benefit varied by client. Greenwald and co-authors noted limitations, including non-representative and dated survey sampling, lack of randomization at the individual level, therapist trainee samples and non-patient targets in the workshop studies, absence of fidelity checks, and a narrow focus on EMDR therapy and progressive counting, which limited generalizability to other PTSD treatments such as prolonged exposure. They concluded that effectively treating any related trauma memory, particularly earlier and less overwhelming ones, tended to reduce distress in more significant related memories and could therefore be used strategically to prepare clients with limited affect tolerance to face the more difficult trauma memories more safely and efficiently. In February 2026, Pehi and co-authors published a single-center retrospective cohort study exploring the role of therapeutic alliance and treatment intensity with 138 adults who completed EMDR therapy in a private outpatient clinic in the Philippines between 2022 and 2025. These adults had all been diagnosed with PTSD by their treating clinicians. Their PTSD symptoms were measured with the PTSD checklist for DSM-5 at baseline, mid-therapy, and post-treatment. Therapeutic alliance was assessed once at roughly the midpoint of their therapy using the 5-item Agnew relationship measure. Treatment episodes included both EMDR only or EMDR with adjunctive interventions such as CBT, DBT, or acceptance and commitment therapy. Treatment intensity was defined as the total number of completed EMDR-focused sessions. However, actual session counts, such as mean, minimum, or maximum number of EMDR sessions, were not reported. Instead, they merely reported session numbers in the regression tables as a predictor labeled treatment intensity. Pehi and co-authors found that PTSD scores decreased significantly from a mean of approximately 44 at baseline to about 38 at mid-therapy to about 30 at post-treatment. They found that the therapeutic alliance did not predict early symptom change from baseline to mid-therapy. As treatment continued, they reported that the therapeutic alliance did correlate strongly with overall symptom reduction, accounting for about 1/5 to 1/4 of the variance. Treatment intensity significantly predicted overall and late-phase symptom reduction. Cases treated only with EMDR therapy showed greater improvement than those treated with EMDR therapy plus adjunctive therapy. This difference may have reflected lower baseline complexity rather than superiority of EMDR therapy alone, or it may have been associated directly with an increased dose response. Pahey and co-authors note the limitations related to the single-center retrospective design, a reliance on routine clinical data without a control condition, exclusion of dropouts in cases with incomplete measures, and unmeasured factors such as baseline severity, dissociation, therapist effects, and treatment fidelity. Pahey and co-authors concluded that in routine EMDR therapy for PTSD, higher treatment intensity supported greater symptom reduction, with therapeutic alliance operating as a parallel additive factor for change. In their summary, they also concluded that stronger therapeutic alliance predicted greater subsequent symptom improvement rather than the reverse. However, with only a single-point measurement in the alliance, I questioned this conclusion. So I corresponded with Ron Gabriel Pahey. In his reply, he acknowledged that without multiple repeated measurements of the therapeutic alliance and cross-lagged or longitudinal modeling, it was not possible to make clear causal or directional inferences. And he acknowledged the strength of the earlier evidence summarized by Kasdan in 2007, supporting the possibility of the reverse relationship, where, in several treatment outcome studies, symptom improvement had been shown to strengthen the therapeutic alliance. What do you think? Read both articles listed in the references and come to your own conclusion. Does a stronger alliance produce a better response to EMDR therapy, or do benefits from EMDR therapy's reductions of symptoms lead to a stronger alliance? In January 2026, Nimi and co-authors published a single-group, waitlist-controlled study of prolonged grief in the journal Omega. 43 bereaved adults completed a 1-month baseline period with 2 assessments, followed by 2 90-minute sessions of an EMDR therapy-derived intervention for chronic bereavement delivered either in person or via telehealth. There was a 1-month follow-up assessment. They then carried out analyses with repeated measures of variance using reverse Helmert contrast. The primary outcomes were grief severity on the International Prolonged Grief Disorder Scale and a single-item rating of average daily sadness. And secondary outcomes were the Depression, Anxiety, and Stress Scale, the Hogan Grief Reaction Checklist subscales, and the Continuing Presence subscale of the Ongoing Attachment Inventory, along with the reported occurrences of after-death communications and a rating of treatment acceptability. When working with chronically bereaved individuals with EMDR therapy, it is not uncommon for clients to spontaneously report experiencing internal dialogue with a deceased person or a felt sense of their presence. The treatment strategy used in this study builds on the earlier work of Botkin, who first described the intervention in 2000 and gave it the provocative name of induced after-death communication therapy. The authors of the current study describe any experience of sensing the presence of a deceased person in some way as, quote, an after-death communication. Their report acknowledges that clients do not need to sense the deceased in order to receive benefit from their version of EMDR therapy. Nimi and co-authors found statistically significant reductions from the average baseline to 1-month follow-up in global grief severity and average daily sadness, with effect sizes of 1.56 and 1.33 respectively, and large improvements across all Hogan Grief Reaction Checklist subscales and all depression, anxiety, and stress subscales. About 1/5 of participants met criteria for prolonged grief disorder at baseline, 1/5, and this proportion decreased by 2/3 at follow-up. Treatment gains did not differ by delivery format, time since loss, or initial grief severity. Because the authors used a simple repeated measures ANOVA, on a small single group. The reported results blurred together any influences of time, spontaneous recovery, expectancy, and other non-specific therapeutic factors. It is impossible to know how much of the reported change was due to their specific intervention versus just plain therapy plus time. Their use of reverse helmet contrast focused almost entirely on one comparison, baseline average versus 1-month follow-up. Their choice of analysis supported an appearance of a strong pre-post story, but gives little nuance about when change actually occurred, about whether gains fluctuated, or whether there were early responders and non-responders. Niemi and co-authors observed that after-death communications occurred for 79% of participants, but they acknowledged that sensing the deceased did not significantly moderate change in grief or sadness. Unsurprisingly, they reported that those who had such experiences reported significantly higher continuing presence scores. Pre-treatment continuing presence was positively associated with sadness, whereas this association disappeared at follow-up. Participants rated the intervention as highly acceptable, with most reporting feeling lighter or better able to move forward. Niemi and co-authors noted key limitations, including the absence of an active comparison treatment, the modest sample size, and the small number of participants meeting diagnostic threshold at baseline, which constrained conclusions about mechanisms or meeting diagnostic criteria. Overall, Niemi and co-authors concluded that EMDR therapy appeared to be a brief, efficient, and promising option for reducing grief-related distress and daily sadness across a range of bereaved adults, warranting a larger, randomized trial against other grief-focused interventions. Listeners who want to read such a randomized controlled study using the standard EMDR therapy protocol for grieving individuals will find a link in the references to the report from Larissa Meisner, Prudence Cotter, and Chris Lee, published in 2016 in the Journal of EMDR Practice and Research. Next, we turn to a different type of speculative article. This is a report about a hypothesis for the possibility that EMDR therapy has effects not only on the autonomic system, but on the immune system as well. In February 2026, Yulia Milanova published a hypothesis and theory article that outlined an integrative neuroimmune model for the effects of bilateral stimulation as used in EMDR therapy. The article drew on evidence from randomized controlled trials and meta-analyses supporting EMDR therapy for PTSD and related conditions, along with psychophysiological, neuroimaging, and basic science studies on autonomic regulation, meningeal lymphatic vessels, regulatory T cells, and microglia. Milovanov proposed that bilateral rhythmic stimulation in EMDR therapy acts as a patterned somatic input that rapidly shifts autonomic balance toward parasympathetic dominance, altered vascular tone, and cerebrospinal fluid dynamics, and thereby modulates meningeal and cervical lymphatic flow. This lymphatic modulation was hypothesized to bias immune surveillance toward regulatory T cell-centered activity, which in turn influences microglial activation, synaptic stability, and network-level recalibration, ultimately supporting durable improvements in emotional regulation, cognitive flexibility, and stress responsiveness. Milovanov extended this theoretical model to autism spectrum disorder and stress-related conditions, suggesting that bilateral rhythmic stimulation might gradually enhance sensory and emotional regulation, with downstream gains in language, social engagement, and stress tolerance via improved neuroimmune balance rather than direct cognitive targeting. The article acknowledged that this model is speculative and avoided asserting definite causal pathways. Milovanov concluded that framing EMDR therapy's bilateral rhythmic stimulation as a modulator of autonomic, lymphatic, and regulatory immune pathways offers a biologically plausible, empirically testable account of how behavioral interventions might engage endogenous regulatory systems to support long-term neural and behavioral stability. The next provocative study asks the question, do patients with PTSD need to be conscious of their memory for it to be reprocessed? In a sophisticated series of experiments, the researchers explored the extent to which a traumatic memory needs to be activated for patients to successfully resolve its disturbance and to recover from PTSD. But first, a little background on the human perceptual system. Brain research has identified two distinct pathways for visual perception: a slow, conscious route that runs from the retina to the thalamus and primary visual cortex before connecting to higher visual areas leading to conscious perception. However, there is also a much faster, unconscious route that runs from the retina to the superior colliculus, then to the pulvinar, and then to the amygdala. This faster, unconscious route can be activated by subliminal visual cues that are too brief to be consciously perceived. It is this fast, unconscious route that Yang and co-authors in China explored in a cleverly designed series of experiments published in February 2026. In their experiments, they used analog trauma films, as well as clinically diagnosed PTSD samples, and a subclinical trauma-exposed group to test whether subliminal trauma-related image cues presented during bilateral eye movements, as used in EMDR therapy, can reduce intrusive traumatic memories and PTSD symptoms. In a trauma induction set of experiments, non-clinical participants viewed disturbing films and then completed trauma induction diaries. In the clinical experiments, subjects previously diagnosed with PTSD completed baseline intrusion diaries. These subjects also completed self-report measures, including the State Trait Anxiety Inventory, the Beck Depression Inventory, the Impact of Event Scale Revised, the PTSD Checklist for DSM-5, and visual analog scales of distress and aversion. In each set of experiments, subjects received one or more sessions of bilateral eye movement tasks with either conscious reactivation, unconscious reactivation, or no trauma cue reactivation. The EMDR interventions involved bilateral eye movement induced by following a moving dot on the screen for 11 trials of 24 seconds each at 1 hertz eye movements, or one complete back and forth movement per second. Some of the subjects in the clinical experiment had previously received exposure therapy or cognitive behavioral therapy and had been completely unable to tolerate confronting their traumatic memories. In their first experiments with non-clinical subjects, they found that the unconscious EMDR-based intervention significantly reduced intrusion frequency after exposure to a highly disturbing film compared to either no intervention or to eye movements without reactivation. Unconscious reactivation to the highly disturbing film with bilateral eye movements performed as effectively as conscious reactivation while eliciting significantly lower affect during the session. The second set of experiments were with patients who met DSM-5 criteria for PTSD and who experienced at least 7 episodes of disturbing intrusive memories each week. Each patient provided 6 personalized images representing central elements of their traumatic experiences. For the PTSD patients, there were 4 independent groups, a no-treatment control group, and 3 groups who all experienced treatment with bilateral stimulation: conscious intervention, unconscious intervention, and no reactivation. They found that both the conscious and unconscious reactivation intervention with bilateral stimulation produced the same degree of improvement, leading to about a 67% within-group reduction and a 56% reduction in overall intrusions compared to those in the no-treatment control group. There were even larger decreases for those with the most distressing and high-impact intrusions. Follow-up assessments showed significant and stable decreases over a 2-month period in depression, anxiety, and PTSD symptom severity. 17 patients who had previously been unable to tolerate conventional exposure reported being able to confront trauma cues after unconscious reactivation with bilateral stimulation. Yang and co-authors noted several limitations, including the need for initial conscious provision of trauma-related images, the short 4-session protocol, and a mixture of PTSD samples. Overall, they concluded that unconscious trauma cue reactivation combined with EMDR therapy offered a brief, low-disclosure, emotionally tolerable intervention that effectively reduced intrusive memories and PTSD symptoms and can function both as a standalone option or as a preparatory step, enabling later engagement with traditional EMDR therapy or exposure-based treatments. We turn attention next to a survey of EMDR therapy practitioners in the United States who offer EMDR therapy with intensive formats. Intensive EMDR is defined as consisting of longer or more frequent sessions than the customary once-a-week 50 or even 90-minute sessions. The study was carried out by Angelina Harris and was published in the Journal of EMDR Practice and Research. She used an exploratory qualitative design with 1-hour-long semi-structured online interviews. Subjects were 11 English-speaking, independently licensed EMDR-trained clinicians with experience conducting intensive EMDR therapy. Therapist experiences were explored through interview questions about treatment decision-making, perceptions of client safety, trauma content exposure, vicarious and secondary trauma, self-care, burnout, self-compassion, scheduling and workload, peer support, and confidence in delivering intensive EMDR therapy. There were no standardized psychometric scales. Instead, the analysis relied on therapists' narrative accounts and thematic coding of perceived self-efficacy, clinical confidence, attunement, and professional identity. The main findings identified 5 themes: enhanced self-efficacy in clinical and logistical decision-making, increased clinical confidence in managing complex trauma, unique confidence in outcomes specific to intensive EMDR therapy, mixed but often energizing impacts of longer sessions, and a strong sense of unique professional connection among intensive EMDR therapy practitioners. Therapists reported that witnessing uninterrupted trauma processing and symptom reduction within prolonged sessions appeared to lessen feelings of fragmentation and may help buffer against secondary trauma despite customary levels of traumatic content exposure. Secondary findings suggested that intensive EMDR therapy supported scheduling autonomy, financial viability, and business creativity. Clinicians emphasized the need for robust self-care and boundary setting and for ongoing consultation and training as core professional resources. Therapists reported intensive work allowed fewer total clients, but deeper, higher quality work. Limitations included the small, non-random sample of predominantly female, U.S.-only clinicians. There was no ethnicity data. The study relied on a single researcher for data collection and interpretation. These factors limited generalizability. Angelina Harris concluded that intensive EMDR therapy appears to enhance therapists' professional self-efficacy and resource conservation, potentially mitigating secondary and vicarious trauma while supporting high-quality PTC care. She called for further research on intensive EMDR therapy formats, including with other trauma-focused modalities. Before wrapping up, we turn to 2 reports that focus on the treatment of complex forms of post-traumatic stress and dissociative disorders. The first of these is a narrative review published in February 2026 by Catalan and co-authors that synthesized psychotherapy outcome and process research for adults with the ICD-11 form of complex PTSD. Their review was based on a targeted search of major databases without a formal risk of bias assessment or standardized data extraction. They focused on phase-based treatments, cognitive behavioral therapy, EMDR therapy, trauma-focused protocols, psychodynamic therapy, and integrative approaches that use diagnostic tools such as the International Trauma Questionnaire. They found that standard evidence-based interventions such as trauma-focused CBT, EMDR therapy, and exposure-based treatments generally reduced PTSD symptoms, but showed smaller and more variable effects on disturbances in self-organization, such as affect dysregulation, negative self-concept, and relational problems. Phase-based and modular approaches that began with skills-building interventions, such as skills training in affective and interpersonal regulation, tended to yield broader gains in both PTSD and disturbances in self-organization, while multimodal psychodynamic inpatient programs particularly improved identity and relational functioning, sometimes with enduring benefits at long-term follow-up. Secondary findings suggested that therapeutic alliance, trust, rupture repair processes, therapist empathy and responsiveness, and management of dissociation and attachment dynamics played central, though understudied, roles in maintaining engagement and supporting corrective relational experiences. This narrative review mentioned several limitations, including a narrow reliance on PTSD-focused outcome measures, inconsistent use of complex PTSD-specific instruments, small and heterogeneous samples, lack of randomized controlled trials for psychodynamic integrative treatments, and minimal process research on possible mechanisms such as therapeutic alliance, dissociation, and mentalization. Based on their review, they suggested that treatment of complex PTSD requires personalized, phase-sensitive, and often integrated interventions that combined evidence-based trauma-focused methods with a strong relational focus on safety, emotional regulation, and reorganization of self and interpersonal functioning, which needs to be supported by more rigorous outcome and process research in the future. We conclude this month's review with an article published in February 2026 in the Journal of EMDR Practice and Research of a summary description of the EMDR Toolbox Method that described Jim Knipe's published work. The article from Manuela Spadoni, Paola Anaboldi, and Jim Knipe describes a conceptual and clinical framework grounded in the adaptive information processing model for treating complex PTSD and dissociation. It is structured around a three-part view of traumatic memory that includes reliving, dissociation, and defenses. It describes a graded internal state continuum and makes use of a color-coded parts model. The article describes the EMDR Toolbox Method as relying on visually mapping internal states with the OVALS tool, then using that map to plan EMDR therapy for complex presentation. Treatment progress is inferred from changes in oval size, position, and configuration over time, rather than from formal outcome measures. Within this framework, the OVALS tool functions as the central case formulation instrument that depicts present-oriented parts, trauma-relieving parts, psychological defense parts, and perpetrator-imitating parts. The authors propose that the OVALS tool allows clinicians to see conflicts, dominance patterns, and dissociative distance at a glance. They can choose to share this formulation with patients for psychoeducation and alliance building. Therapists can update the OVALS over a series of sessions to track shifts in present orientation, weakening of defenses, and increasing integration. They can use emerging patterns to decide when to change focus, address blocks, or revise the treatment plan. The toolbox includes several groups of tools. There are tools to reinforce and assess present orientation, which include resource development and installation, mindfulness-based procedures, and the back of the head scale, which evaluates how much the client experiences themselves in the present versus in trauma time, and helps titrate work with highly activated material. There are tools to target reliving, with standard EMDR therapy phases 3 through 8. There are also the loving eyes procedure and the constant installation of present orientation and safety, which enhance reprocessing while repeatedly anchoring the client in safety and current time. There are tools to target psychological defenses, including the level of urge to avoid, the level of positive affect, the what is good about procedure, and the level of urge tool, which are all designed to make avoidance, idealization, and other defenses explicit, reprocess the positive payoff with bilateral stimulation, and open access to underlying trauma networks. There are tools to target dissociation, such as enhanced internal healing dialogue, which structures dialogues between separated internal states so that each can speak, listen while the other speaks, and gradually reduce dissociative distance through sets of bilateral stimulation. Spadoni and co-authors propose that the EMDR Toolbox Method helps therapists to link specific tools to mapped internal states, to stabilize complex trauma presentations, and to manage perpetrator imitating and highly dissociative parts more systematically. They acknowledge that evidence for the toolbox method remains limited to practice-based observations. They underscored limitations such as the absence of controlled trials, the challenges of reliably mapping verbal material to internal states, and the need for advanced training. Despite these issues, they believe that the EMDR Toolbox Method offers a promising integrative extension of EMDR therapy requiring formal research on reliability, safety, and efficacy. That's it for today's episode of EMDR, The Science Behind the Therapy from Sonoma Psychotherapy Training Institute. We hope this podcast helps deepen your understanding of the clinical science behind EMDR therapy. All the articles covered in this 9th episode of the podcast can be found at sonomapti.com/blog in the April 2026 listings. If you enjoyed this podcast, help support the podcast by following, rating, or sharing it with fellow therapists. For information on our unique EMDR therapy training program, visit sonomapti.com, and for free articles on EMDR therapy, visit the resources section on andrewleeds.net. Thanks again for listening. We'll see you next time.